Okay, welcome back to ECG Basics. We're doing a rhythm. This is the second of 2 rhythm sessions just because we had quite a bit of explanation on the first one and just kind of started getting into some explanation and some examples. So if you're joining this video, this is part 2. Make sure you go back and watch ECG Basics Rhythm Part 1. We ended on this slide where we were talking about either sinus arrhythmia, or sinus rhythm that's interrupted with premature complexes. This next rhythm strip, you can see what looks to be an irregular rhythm. And it's an interesting one because at first glance it looks like it could be regular if you're looking at the distance between these R waves here. They all look pretty much the same. However, there's then a very long distance between those two R waves. So clearly there's something irregular happening here. So remember, we have our questions that we want to answer. First, we want to ask if it's regular or irregular. We'll say this one's irregular. We want to then ask if P waves are present. And so we can see P waves regularly present. And then we want to ask the question, is there a P for every QRS, and is there a QRS for every P, right? So let's look at the P waves and see if each of them is followed by a QRS. So this P is followed by QRS, this P is followed by QRS, this one here okay, this one here okay, this one here we see there's no QRS, and then we get another P. So this is going to be a clue to what we're looking at. We can see that there's been a block in the transmission of the electrical impulse from the atria to what should have been the ventricle in here somewhere, but that message got blocked and there was no ventricular depolarization, so we skipped a beat and we ended up going back to our P wave, which is then once again followed by QRS. So we've kind of hit an abnormal on our list of questions. That means we need to explain that. So what does it mean when you have a P wave and there is no QRS? We would call that an AV block, right? An atrioventricular block. That means the electricity is working fine in the atria, but for some reason it misses its way to the ventricles. It gets stopped on its way to the ventricles, and that electrical impulse gets blocked. So there are 3 types of AV block. We call it type 1, type 2, and type 3. Type 1 is just a prolonged PR interval, and we don't discuss that too much. It's easy enough to find. You just measure the PR interval, and if it's more than 200 milliseconds, then it's prolonged. But clinically, it doesn't have a lot of significance unless it gets extremely long. So we don't really bother too much with first degree block. Second degree heart block. So second degree, there are 2 forms, type 1 and type 2. Sometimes we'll say Mobitz type 1 or Mobitz type 2. And then to make it even more confusing, type 1 sometimes goes by the name of Wenckebach. But I think probably what you need to remember is second degree has 2 types, Mobitz type 1 and Mobitz type 2. And second degree, what you'll often see is there is a dropped beat somewhere, that there's a block between the atrial depolarization and the ventricular depolarization. There is then third degree block, which we call complete heart block. This is the most dangerous because it means the atria and the ventricular electricity are not communicating with each other. So none of the electrical impulse from the atria is reaching the ventricles. So the atria are depolarizing and contracting separately from the ventricles, who eventually find their own timing, which tends to be slower than the atria, and they have a separate depolarization. We'll see some examples of that here in a bit. So 3 kinds of AV block. Type 1, which is just prolonged PR interval. We don't worry too much about that. Second degree has 2 types, type 1 and type 2, and third degree is complete. So looking at this rhythm strip, I'll just tell you it's not complete because you can see that most of the time you get good communication from the P wave to the QRS, from the P wave to the QRS. We only actually found one that was blocked. And so this is not complete heart block, but it is second degree heart block. So the next part of our job is to determine if it's type 1 or type 2. So the difference between type 1 and type 2 is type 1 has progressive lengthening of the PR interval, whereas type 2 will have a consistent PR interval. So let's look at our PR intervals and see if they are consistent or if they are getting longer. So if we look at this PR interval, the beginning of the P wave to the beginning of the QRS complex, you can see it's about 6 small boxes, which, by the way, is a little bit long. It should be 5 small boxes or less. So we could say that's first degree heart block if we didn't see this dropped beat, but because there's a dropped beat, it becomes second degree or even possibly third degree heart block. So our first PR interval is, we'll just say 6 small boxes. The next PR interval is 1, 2, 3, 4, 5, 6, 7 small boxes. The next PR interval is 1, 2, 3, 4, 5, 6, 7 plus maybe 7.5. The next one, we have 5. We're up to 9. And then the next one is the one we skip. So what we see here is our PR interval went from 6 small boxes to 7 to a little more than 7 to 9, and then we missed our QRS. So that's progressive PR lengthening. So this is type 1, or some people will call Wenckebach. That's an old term, Wenckebach. We don't really use that much, but you may hear it. So this is Mobitz type 1, second degree AV block. Okay, let's look at this rhythm strip. Is it regular or irregular? That's our first question. So these two look pretty similar, but obviously this one is way longer. So we're going to say this is irregular. Are there P waves? Sure seems to be P waves. Is there a QRS following each P wave? So this P wave has a QRS, this P wave has a QRS, this P wave has a QRS. This P wave, nothing. Should be a QRS, but it's gone. So if you remember the last slide, we say, we have a P with no QRS. That means there's a block there. It doesn't look complete because the other ones seem to make it through. It seems like we only dropped this one. So maybe that's another second degree, right? And then the question is it Mobitz type 1 or Mobitz type 2? So we're going to look at the PR interval. Is the PR interval consistent or is it changing? So look at this PR interval and this PR interval and this PR interval. And if you count them, and even back to this one, you can see that they're all about 4 small boxes. So it's a consistent PR interval. If it's a consistent PR interval, it's called Mobitz type 2. So this is second degree AV block Mobitz type 2. All right, what about this one? Is it regular or irregular? Well, that's, again, an interesting question. We've got, it's fairly regular, actually. Although, what do you notice? If you're doing your rate, it looks very long, doesn't it? We'll try to do our cheat since it's regular. So we have 300, 150, 100, 75, 60, 50, 40, and so it's way less than 40. So we know we have a bradycardia. When you have a bradycardia, that's when you sometimes think about a heart block because that's one of the causes, if it's not sinus bradycardia. Some medications can either give you a sinus bradycardia or can give you an AV block. So we're already thinking along those lines. And then we're going to go through our questions, right? Do we have consistent P waves? There's a P, 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 P. Yep, it looks like we have consistent P waves. Is each P wave followed by a QRS? Well, this P has a QRS. This P, we're missing it. This P, we're missing it. This P seems to have one. This P, nothing. This P, nothing. This P seems to have one, and so on and so forth. So you can see that we are missing some QRS complexes, right? Now we're back to our previous question. Are we having, excuse me, consistent PR intervals, or is the PR interval changing? And this one's going to be a little bit tricky, but we'll count it out here. It looks like this one is about 6 small boxes. This one is 7 small boxes, and this one is also 7, so no big change. So there does seem to be some change, but really not progressive lengthening like Wenckebach or type 1, Mobitz type 1. And it's also not consistent like Mobitz type 2. So that's your first indication that this might be a type of block. We see there's a block because we've got P waves with no QRSs, but it doesn't really fit Mobitz type 1 or Mobitz type 2. Something that you can see if you're observant on this is that you have very regular marching of P waves. You have P, 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 very regular, very consistent. And then you get a QRS, and then your P's return very consistent, a QRS, and your P's return very consistent. If you look at the QRSs, you may actually find evidence of a P wave that's hiding inside the QRS. This is the one that's easiest to see. You see that extra bump inside just before we get to the T wave or just at the beginning of the T wave. And if you marched it out and you looked there, P, 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 look at that. It marches right along. So there's actually a P wave hiding in there. And you might imagine there's a P wave right in there, which would march right along with the other P waves. So when you have P waves that are marching consistently like that, and you've got slow QRS complexes that are wide, and we'll talk about what makes them wide in another lecture, but they're wide, they're slow, and they don't seem to be really interacting with the P waves. So the P waves seem to be marching at their own pace, and the QRS complexes seem to be marching at their own slow pace. This is what we call complete heart block. Complete heart block, or third degree heart block. So this patient, if you saw this, you'd want to get them on a temporary pacemaker and then get them to the cardiologist as soon as possible in order to get a pacemaker put in. This patient's not going to survive with this kind of heart block. So this is complete heart block. Okay, this next one, we're going to look at a series of full ECGs now, just to kind of give us a practice of seeing them, the full ones that you'll be reading in the future. But remember, because we're doing our systematic approach, we're only going to look at the rhythm, okay, especially for the sake of this lecture. You have learned how to do the rate if you looked at the previous lecture, so we could also look at the rate. Hello. Fantastic. Yeah, thanks. Bye. Sorry for that delay and brief interruption. Back to this EKG, we can see the whole EKG, but what we're gonna do is focus on what's called the rhythm strip, which you'll often see on a 12 lead, is at the bottom of your 12 lead ECG, where they will give you one lead for the whole time period. And most often it's lead 2. And the reason is that lead 2 is probably the best place to look for P waves. And because we know that really our determination of the rhythm starts with the presence or absence of P waves, it's really the best lead to look at. So lead 2 is great for trying to look at the rhythm. So in this case, we have a rhythm strip on the bottom of this 12 lead ECG that is showing us lead 2 for the entire time period. And that's the best place to look for your rhythm. So remember, the first question is, are there consistent P waves? And on this ECG, that's a little bit of a difficult question to answer. You can see that there are definitely QRSs and there are Ts. The question is, what is this thing that you see consistently right before the QRS? Is that a P wave? And that's understandably difficult to say, especially if you're not used to reading ECGs. Some of you might say, yeah, that looks like a half a P wave. Some of you might say that just looks like another T wave, or that just looks like some random bump. So we're going to start out by saying it's questionable if we actually see P waves, right? So then if there are no P waves, then you really can't answer the next questions, right? You can't answer the question about are the P waves, or do they look the same? You can't answer the question about, is there a QRS after every P, and is there a P before every QRS? So you really can't answer those questions. And you really can't answer the PR interval. So if we say that we're not sure that there's really P waves, really the next thing to say is this regular or irregular? And if you're just take a sample here of QRSs, I would say, generally speaking, they look pretty regular, and that's pretty consistent through the whole rhythm strip. So I would say this is a regular rhythm with questionable presence of P waves. If they are P waves, they're pretty consistent. PR interval is consistent. There's a QRS after every P. So the next question is going to be, what's the rate? If we go back to step 1 of our 6-step process, step 1 is rate. And if you look at the rate, we can kind of try to do our cheat, try to find one that sits on here's one, a QRS that sits on a bold line. And we would say that's 300, that's 150, and it's just off of 150. It's very close to 150. If we take another example, let's say this one here, that one's just before the bold line, and that one's just after. So we say, it's probably just a little under 150. But it's very close to 150. And in fact, if you counted all of the boxes and all of the QRS complexes, you would get almost exactly 150 if you did this the longhand way instead of our cheating way. And when you've got a tachycardia, you've got a fast rhythm that's very regular with questionable P waves and is almost exactly 150, you should think atrial flutter. And that's actually what we have here. We have atrial flutter. This is an instance where the SA node is sending out an electrical signal way faster than it should, and only some of those are getting through to the ventricles. So in this case, we're getting 150 beats per minute on the QRS complex, but that P wave is firing pretty much every 300. Well, enough to give you a heart rate of 300, and every other one is being blocked, so you end up getting what we call a 2-to-1 block, and you end up with a rate of 150. You can have a 3-to-1 block, and your rate would be 100. You can have a 4-to-1 block, and your rate would be 75. So if you're seeing these kind of funny-looking P waves, and you're not sure if they're P waves or not, but you have a number that's almost exact, 150, 100, 75, consider atrial flutter, which is what we see here. All right, let's look at this one. Again, we've got the whole 12-lead ECG, but we're going to focus on the bottom here, lead 2 in a rhythm strip. First question, of course, is this regular or irregular? And I think you can tell just from a quick look that this is irregular. Just as an example, let's pick the distance there, that distance compared to that short distance, and that's a medium distance. So we've got 4 beats in a row there that aren't even consistent. So this is definitely an irregular rhythm. You can see here's another long, here's another short, there's an even shorter. The distance between the R waves is just changing with every beat. So we would say this is definitely irregular. The next question is, are there consistent P waves? And if you're looking all around, especially at this lead 2, you would look and say, I don't know, maybe that's something. That's probably a T wave. Nothing there, nothing there, nothing there. I don't know, a little bump there, nothing there, maybe a little bump. In general, you're looking around saying, I don't think there are consistent P waves, right? No P wave, no P wave, no P wave, no P wave, no P wave. No. Most of them, you're sure, have no P wave. Occasionally, you might see a little bump, and you might question, is that a P wave? Let me just encourage you to put the word in general in front of the statement. So in general, are there P waves? And we would say, in general, no. Even if I think I see a bump every now and then, if I don't see it regularly or consistently, they're not P waves. So we have an irregular rhythm and we have no P waves. If you've got an irregular rhythm with no P waves, you basically have your rhythm. There's only one thing that does that, and that is atrial fibrillation. So this will become one of the easiest rhythms for you to identify. Sorry, no S there. Atrial fibrillation. Very common, especially in older patients. The patient may come in with palpitations or feeling that their heartbeat is fast or irregular, or they may have no symptoms and you may just find this coincidentally. Okay, here we have another full 12-lead ECG, but we're going to focus here on the rhythm strip, which is showing us lead 2 for the entire time period. First question is it regular or irregular? I think you can see that it looks regular. You can probably also see, especially if you've gone through the rate lectures, that this is quite fast. So let's pick, this one is almost on a bold line, so we would say 300, and that's 150, so it's between 300 and 150. Let's pick another one that's on a bold line, if we can find one. Boy, they're hard to find, aren't they? Here's one. That's on a bold line, and there we are again. So faster than 150, slower than 300. You probably would have to count this out. I'm guessing this is 170s, 180 maybe for a heart rate. So this is quite fast. So we have a tachycardia, but it's a regular tachycardia. So the next question is, do you see P waves? And I would argue that we do not see P waves. We see T waves. These are T's, right? All those are T's, but there's really not space. The heart rate is so fast that there's not even space for the P wave to be seen. So what we have is a fast, regular tachycardia with no P waves. And remember, we talked about atrial flutter. That's also a way that you could describe atrial flutter. You could say, if it was fast, if you had a tachycardia, you would say it's fast, it's regular, not sure I see P waves. So the clue for atrial flutter was, is it exactly 150 or close to it? And if it is, consider atrial flutter. In this case, we're saying the heart rate is about 180, so it's not atrial flutter. So when you have a regular tachycardia that's greater than 150, narrow QRSs, very regular like this, this is another very common rhythm we call SVT. That stands for supraventricular tachycardia. So this is a common one that you'll see. It's really common in young people. If a young person has palpitations, this is probably what you're going to find if you do the EKG, if there's an abnormal rhythm. And it's fairly easy to identify once again. Once you see it, very fast, very narrow, very regular, more than 150 supraventricular tachycardia. Okay, same deal here. We've got another 12 lead, but we're going to focus on the rhythm strip, which is lead 2. You'll see that commonly. First thing you should recognize is that this looks weird. We don't have any of our normal bumps and squiggles, right? All we have is what looks like a big sawtooth going all the way across. No T waves, no P waves. Not even sure if these are QRSs or T waves or what we have going on here. So first question, though, that you always come to is it regular or irregular? And let's say that these are the R waves. They march out pretty regular. So we actually have a regular, tachycardia. So we've got, let's see, here to here, that would be about 150, right? That would be 300, that would be 150. So our heart rate's about 150. But what's different from this and the atrial flutter we saw that was also 150? Remember, the atrial flutter actually looked like a regular ECG. You had T waves, you had QRS complexes, you thought something that could have been a P wave, right? This one has just very wide QRS complexes. That's it. These squiggles are wide QRS complexes. So when you have a fast, wide, regular tachycardia, you know that this is what we call ventricular tachycardia. And my pen is not wanting to write right now. Ventricular. Okay, so the last one was supraventricular tachycardia, if you remember, and this one is ventricular tachycardia. So it's not coming from supra. On the previous slide, supra means above the ventricles, and so you get a narrow complex. Once the stimulus for contraction moves into the ventricles, you get a wide QRS complex. This is very wide. And now it's not supraventricular anymore, it's now ventricular. So this is called ventricular tachycardia. This is potentially a very dangerous rhythm that can actually result in cardiac arrest. And so if you see this, it needs to be taken care of immediately and emergently. All right, let's look at this one. Here we are getting a 12 lead ECG with lead V1 actually as our rhythm strip instead of lead 2. And again, a very funny looking picture. I just want to show you a picture of this, something that you might see on a test. Rarely have I seen it in real life, but I have seen a few cases of something called torsades de pointe, which is French. If my pen was working, I'm so sorry it stopped. I could spell that for you. Torsades de pointe, and you can look this up for the spelling. But what you get is an initial wide complex tachycardia, kind of like we saw in the previous picture, that wide ventricular tachycardia. It then gets narrow in the middle, you can see, and then it gets wide again on the end. So you've got two wide complexes in the middle with a narrow complex. When you see that, and of course you don't have the regular architecture, right? You don't have P waves, you don't have T waves, you don't have any of your intervals. You just got kind of that sawtooth pattern that starts tall, gets short, and then gets tall again. When you see that, that's torsades. Looks like my pen might want to work. There we go. Torsades de pointe. It's French, and you can look that up if you want to. So this is also a very serious rhythm, can result in cardiac arrest similar to the ventricular tachycardia. There is sometimes a magnesium deficiency with this, so often if we see this, we will give the patient magnesium and be ready to have electricity standing by to give them an external shock if we need to. Okay, so we've actually looked at several common dysrhythmias in this, and we've looked at what is the approach to rhythm, right? So remember, in the big scheme, we're looking at the systematic approach, right? So step 1 was to determine the rate. That was a previous lecture. Step 2 is to determine the rhythm. Now, the rhythm and the rate are connected, and often in real life we're doing them kind of simultaneously, because when you look at the rate, the first thing you want to ask is it regular or irregular? But you've probably already done that when you looked at the rate. So sometime with the rate or the rhythm, you've got to ask that question. Is this regular or is this irregular, right? Because that's going to really determine what your options are. The next question is, are there P waves consistently present? If the answer is no, and it's irregular, then that's atrial fibrillation. If the answer is no, and it's irregular tachycardia, then you've got a couple options. Could be SVT, could be atrial flutter, could be ventricular tachycardia. Then you ask, do the P waves generally look the same? Really, all you're looking for there is what we called MAT, multifocal atrial tachycardia. So if there are consistent P waves, but they keep changing their appearance, and you have tachycardia, then you have MAT. Is there a Q wave before every, is there a P wave before every QRS and a QRS after every P? You're really looking for blocks there, right? Those questions are looking for blocks, such as our Wenckebach or our Mobitz 2. And then, is the PR interval consistent? That also helps you determine which of the blocks you might have. So remember those questions when you're looking at rhythm, and I think they'll be very helpful. So we have finished now 2 of our 6 components. We've done rate and rhythm. Next will be axis, followed by intervals. Please look for those videos to come up here in the next week or so.